Okay, let's get started. Hi, everybody. My name is Paul Jacobs. I'm a grateful Texas lawyer assistant program professional. I'm going to share a little bit, introduce myself, then introduce Dr. Shorter, and then we're going to have a wonderful presentation. Real briefly, for some of you who don't know me, I'm currently a professional at Texas Lawyers Assistance Program, one of 5 people in the program. And before that, I was a civil trial lawyer in Houston, Texas, primarily for over 30 years. I was earned board certification in civil trial law, personal injury trial law by the Texas Board of Legal Specialization, and was earned board certification in trial advocacy by the National Board of Trial Advocates. The topic that Dr. Shorter is going to share with you is very close to my home. So I'm in long-term recovery after over 25 years of practice as a consequence of significant acute and chronic direct and indirect or secondary trauma. I burned out. I was in denial of that fact. I had what I call the self-reliance disorder and tried to diagnose and treat myself. And that did not work very well. And so I'm grateful to be in long-term recovery now. I wish I had the courage to call Dr. Shorter or somebody at the Menninger Clinic or program like that when I was suffering, and I'm glad we'll get some awareness today. So now Dr. Shorter. Dr. Shorter is the current medical director of the addiction services at the Menninger Clinic in Houston. For over 95 years, the Menninger Clinic has diagnosed and treated people with mental health disorders, as well as substance use and other conditions. Highly trained teams of mental health experts provide a supportive, healing environment coupled with evidence-based and biological treatments that is person-centered. Dr. Shorter is board certified in addiction psychology, psychiatry, and adult psychiatry. He is an associate professor in psychiatry and behavioral services at Baylor College of Medicine. Dr. Shorter received his BS degree at Rice University in Houston, his medical doctorate at Baylor College of Medicine, his psychiatric residency at the Ohio State University, and his psychiatry fellowship at NYU. We're very grateful and fortunate to have Dr. Shorter with us today. I'll turn it over to Dr. Shorter. Thank you all.
Thank you so much for the gracious introduction. I'm really quite thrilled to be with you today to talk a little bit about recovery among attorneys specifically. I will dive right in because I want to make sure that we have some time toward the end of the presentation, toward the end of the hour, to have more of a conversation. So hopefully you will utilize the Q&A function and the chat function during the course of the presentation so we can interact a little bit more. My hope today is to really speak only about 40 to 45 minutes. I have been accused correctly of being a little long-winded, so this is going to be really me trying to curtail my natural tendency to talk too much. So I'm going to go ahead and share some slides with you, and we can go ahead and get started. And this talk really initially started off as what I thought would be a talk mostly about addictions and addictions work. As was mentioned, I am a board certified addiction psychiatrist, so I take care of folks who are struggling with substance use disorders as well as behavioral addictions. But what I've figured out over the course of preparing this talk is that some of the challenges that are specific to attorneys really, I think, are much broader than just addiction. And so we'll be talking a little bit about depression, anxiety, trauma, some other behaviors as well. I'll be mentioning those over the course of the next hour. So I have no financial conflicts to disclose. So for the purpose of today, I'm going to talk a little bit about mental health and substance use disorders, as well as some prevailing models of addiction. And I'll talk a little bit about why I think that that's important. I'll review some data on mental health and substance use disorders among attorneys, as well as risk factors for the development of mental health or substance use disorders specific to attorneys. And then in the final bit of the talk, I'll define what a recovery process is, and then maybe offer some solutions that your organizations and clinics and firms can think about in terms of the promotion of recovery specifically among attorneys. So I always think it's a good idea when talking to folks to really try to define mental health conditions, what it is that I'm talking about here. As many of you probably know, we utilize the DSM-5. We are now currently on the newest text revision of the DSM-5, which just came out this year. And that's our diagnostic and statistical manual of mental disorders. It really allows us to systematically diagnose both mental health and substance use disorders. When I'm talking about neurodevelopmental and neurocognitive disorders, I know it may seem like on the surface that we're not necessarily talking about a category of disorders that can impact attorneys, but as it turns out, attention deficit hyperactivity disorder, or ADHD, is part of that category of disorders and could certainly impact someone in the practice of law. Schizophrenia and other psychotic disorders, such as schizoaffective disorder, may not necessarily be as commonly seen among attorneys, but one thing we do know about the development of schizophrenia is that over the course of one's lifetime, although it's most likely that someone might develop that condition in their late teens or early 20s, that the development of psychotic disorder certainly can take place over the course of one's life. And so attorneys, as it turns out, are not necessarily immune to the development of psychosis. We'll talk a lot about depression today, but certainly bipolar disorders can be seen commonly in folks. And interestingly, bipolar disorder has what we call a bimodal distribution in terms of the age of onset. So people are most likely to develop bipolar disorder either in their 20s, perhaps during law school, and with kind of struggling with the stress of law school, or even later in their 50s. So if you are in your middle age or approaching that area, that time in your life, bipolar disorders as an age of onset can also occur then as well. We'll spend a lot of time talking about anxiety and anxiety disorders, but these things include not just our generalized anxiety disorder. They can also include things like social anxiety disorder, panic disorder and panic attacks, as well as some of the obsessive compulsive disorders. And we used to sort of group anxiety disorders and obsessive compulsive disorders together, but now we understand that OCD is kind of its own separate biological condition and can include other disorders like body dysmorphic disorder, which we'll talk about potentially as we think about some of the disordered eating that can take place in folks that are attorneys. Trauma and stressor-related disorders, I think we don't necessarily kind of associate a career in the law with the development of like a traumatic related disorder. However, it turns out because of vicarious trauma, which we will talk a little bit about today, certainly the development of PTSD-like symptoms, as well as meeting full criteria for PTSD is something that can be seen among certain subsets of attorneys. Substance-related disorders, addiction disorders, behavioral addictions, of course, are sort of the one of kind of the crux of it. And that can include things ranging from alcohol to all kinds of other substances, some that are sometimes used in the treatment of other conditions, like opioid medications being used to treat chronic pain, benzodiazepines used to treat anxiety disorders or other neurological conditions, as well as illicit substances, cocaine, methamphetamine, heroin, etc. Eating disorders, it turns out, we talk mostly about anorexia and bulimia, but there's sort of a spectrum when it comes to eating disorders as well. As I mentioned before, disordered eating is something that you can see perhaps more commonly among attorneys than you might think. And finally, to sort of round it out, personality disorders. And we sort of think about personality as a way of the way that one sees oneself. The way that one views the world is another aspect of our personality. Our level of impulsivity can certainly be impacted by personality, as well as the nature of our interpersonal relationships. And so our personality really is not just something that comes up in isolation of other people, but really is about how we interact with other people, family, friends, and even people that aren't necessarily that close to us. So I want to start off by telling you about an attorney in my practice. So as was mentioned in the bio, I am in practice here at the Menninger Clinic. In addition to seeing folks who are on our inpatient service who might be struggling with a substance use disorder, I also have a very small outpatient clinic where I take care of folks. This is a gentleman, he's 44 years old. He's been married for about 20 years. He and his wife have 2 children, age of daughters, age 16 and 10. And he came to me because his wife had expressed concern specifically about his drinking. He had always been a social drinker. Excuse me. He'd always been a social drinker, and there had been a period of time in his life where alcohol-related concerns, primarily in his 20s and 30s, weren't really a part of his life or his family life. He found that his work and his routine had been really significantly disrupted by COVID, which is something that we have seen extremely commonly entering into our treatment settings. I mean, the number of folks that come in who have had an escalation in their depression or anxiety or in their alcohol or drug use over the last couple of years, in my opinion, has been really, and experience has been really tremendous. And so COVID absolutely represents a risk factor for most people. And that certainly was the case for this guy. He found that his work became first a little spotty, of course, during the earliest part of the pandemic, and then his routine was completely disrupted by COVID as well. Earlier this year, he had an episode of drinking during a time of family tragedy. Essentially, his father-in-law was passing away, and during the time that his father-in-law was passing away, and he was really being looked to by his wife, by his children, as a source of support and stability. He was really not able to provide that kind of support and stability to them because of drinking. So since that incident, which happened now, March, about 4 or 5 months ago, he has been what he describes as generally sober. What he means by that is he doesn't really drink when he's at home or in town, but if he happens to take a work-related trip, he may drink while doing work. So if he has meetings and there's a dinner in another city or another town, then he may engage in alcohol consumption at that time. But for the most part, when he is in town, and certainly when he's around family, he remains abstinent from alcohol, excuse me. In terms of the impact on other domains of his life, what we found is that his family life has been primarily impacted, but he continues to excel at work. So not necessarily having any problems in terms of billing hours or anything like that, but the conflict with his wife continues. He really describes no history of depression or anxiety. And when I meet with him, he continues to deny that he's depressed or anxious. Now, he has been treated for depression in the past, like remote past, but even in those cases, no medications were prescribed for him, no antidepressants, and no anti-anxiety medications. So this is sort of like, I think, one way that someone can present for treatment, and hopefully it gives you kind of a glimpse into what it is that we might see clinically for someone now, especially in the aftermath of COVID. So I want to talk a little bit about models of addiction. This has been something that I think has become increasingly important to discuss because it turns out that the way that you think about what constitutes an addictive disorder entirely determines how you might approach or not approach dealing with it. Okay, so when I started off at Menninger, I was kind of surprised to find that among many of my colleagues, we don't necessarily share the same understanding or model of addiction. This is also something that I have seen in other treatment locations as well. And the reality is that in the field of addiction, there's not necessarily widespread agreement about what constitutes an addictive disorder. When you start studying addiction or start thinking about like, well, what causes addiction? What are the underlying components of it? It turns out that there are well over 100 models of addiction, okay? Well over 100. And I think that that bears repeating because it helps us to understand why it is that there are so many different ideas about what caused it and what someone should do about it. So I'd like to talk about the prevailing models of addiction that are currently sort of circulating within the cultural zeitgeist as well as within the field. The moral model is where I'll start. And it's interesting because I think people, excuse me, try very hard to kind of divorce themselves from what constitutes the moral model. But the reality is that we all carry some of this moral model thinking. In the moral model of addiction, we tend to think of it as being a problem of moral weakness, a lack of willpower, or as a result of bad or evil character. Now, the way that this might actually kind of come out in someone's conversation is they may say things like, I don't know why he doesn't just get it, or I don't know why she can't just control her use. I don't know, on the treatment side of things, people say things like, I don't know why he or she is not motivated for treatment. This idea that that people should have this great amount of insight into what it is that's going on with them and then just do something about it. In the moral model, the idea is that someone would either increase their willpower against temptation. And this I remember, especially when in my work prior to coming to Menninger, patients would come in and they would say, I just need to go back to church or synagogue or temple or whatever it is. I need to get right with my higher power or get right with God. I prayed about this, but those sorts of attitudes or beliefs about how to go about treating the addictive disorder. So religious counseling becomes a major part of how someone might deal with an addictive disorder if they're operating from within the moral model. And a type of conversion might also be a part of that. And I'm sure we've all heard these stories about people having these sort of lightning bolt moments of insight where they decided for the rest of their lives that they will never engage, and it's all about willpower. And we sort of celebrate that. That's the moral model. As part of the moral model, one treatment approach, especially if one is kind of thinking about this as it might relate to some mutual help groups or such, moral inventory can actually be a really important part of this. Like, how can I develop a better sense of my identity and my sense of self? And one way of going about doing that is through a moral inventory. It also centers the person as being responsible, not necessarily for what caused their addictive disorder, but really for treating it or addressing it. The problem with it, however, is that it can sometimes, and for some people, feel very blaming, sort of punitive. And ultimately, I think a lot of people find that despite their tremendous will, especially willpower in other areas of their life, they find that their willpower is not necessarily effective in managing an addictive disorder. There's the biological model, or a medical model, which is sort of where I tend to lean or tend to land, because I like to think a lot about the genetics and the family history and temperament, personality, some of the other biological aspects that contribute to why it is that someone might develop an addictive disorder. Abstinence is the goal in a medical model, but is it? And we'll talk about that a little later. I do believe in the use of medications in order to promote abstinence, to reduce craving, to manage withdrawal symptoms. And the idea behind the biological or the medical model is that it's not intended to be particularly blaming, and that if someone has a disease, that they can seek treatment in order to alleviate the symptoms of their addictive disorder. I think by far the most consciously recognized model of addiction is self-medication. People come into my office all the time and they say, well, I'm self-medicating my blank. And they'll say my depression, my anxiety, my sleep. Sleep is another major thing that people are medicating. And so the attribution of the addictive disorder to another kind of psychiatric or psychological condition. So the idea in that case might be psychotherapy or pharmacotherapy of the mental health condition. The challenge with self-medication is that oftentimes the substance use disorder is not secondary to something else. It is in addition to. By that, I mean, people have two things at the same time and they have a relationship. They may be interrelated or connected, but it's not necessarily that one is causing the other. In fact, what we know is that substance use is more likely to cause depression, more likely to cause anxiety, more likely to cause insomnia rather than the other way around. And people can kind of get lost in that loop. The final one, and I think that this actually is going to matter as we talk about recovery among attorneys, is that there are environmental or social influences that certainly can add to or contribute to one's use of substances. Now, the nice thing about it is that it really emphasizes the need for development of coping skills and coping strategies, which obviously I think is critical for someone who's trying to enter recovery from either mental health or a substance use disorder, as well as integrating with other models. So you don't have to just be sort of a strict medical biological modelist. You can also incorporate the social model and help people to kind of think through their peers, the peer influences, family, et cetera, et cetera. The challenge is that it's often easy for people who operate strictly from within the social model to externalize and blame others for why it is that the person might be struggling with a particular kind of disorder, mental health or otherwise. So let's dive in now that we kind of have an understanding of some of these models. And again, that is a very partial list of the models that exist. As I mentioned, there are over 100 models. And but just to kind of maybe complicate our understanding of what constitutes addiction, that it is very complicated because there are lots of different ways of understanding what constitutes an addiction. Okay, so now we've talked about that, I want to transition specifically into lawyers and talk a little bit about how mental health and SUDS impact your profession. So perhaps you are familiar with this very early study. It's a Benjamin et al. 1990. It was a study of attorneys in Washington state. And what they found in this group, in this cohort, was that almost 20%, roughly 18% of Washington state attorneys at this time were identified as problem drinkers. And back in 1990, that was two times the prevalence of alcohol abuse and dependence in US adults. Excuse me. For the record, since 1990, we have updated our understanding of what constitutes alcohol use disorder. So we no longer really use the designations of alcohol abuse or alcohol dependence. Those diagnoses no longer exist in the DSM-5. We speak only about alcohol use disorder, and we talk about it either as mild, moderate, or severe in terms of the levels of severity. When it comes to depression, almost 20% of that population reported being depressed, and in comparison to about 3 to 9% of individuals in Western countries. So for years and years, we've known that attorneys represent a group in terms of a professional group that has an increased risk or likelihood of having either problem drinking or depression. In a much more recent study of law students, it turns out, experience higher levels of stress, anxiety, and depression in comparison to other types of university students. And interestingly, as I mentioned, there was an increased risk of disordered eating as well as psychological distress. So when I talk about disordered eating, I'm not necessarily talking about a DSM-5 diagnosis of an eating disorder. So these aren't necessarily people who would have met criteria for anorexia or criteria for bulimia, but they did have symptoms of those disorders. That also might come across as or come out as excessive concern about their weight or their shape. It might also be associated with binge eating, as well as other types of compensatory behaviors, such as over-exercising, restricting calories, diets, that sort of thing. So when people engage in those sorts of compensatory behaviors, and we'll talk about this as it relates to risk factors in a second, those sorts of compensatory behaviors may be even more pronounced among law students. And probably one of the more widely cited studies or surveys that has recently come about is this email sort of web survey that took place in over almost 13,000 employed attorneys. That's a very large number of folks, to be sure. And multiple states were covered. So 15 state bar association, 2 counties. So they got about 17 to 19 states covered. The split was mostly men, about 53% men. Majority of the folks that were answering the survey were between ages 31 to 40, although it ranged all the way up to folks as in their 70s also taking the survey. And in this population, over 90% were white. So when they looked at this, they found that 21% of those responding to the survey had a positive screen for hazardous, harmful, and potentially dependent drinking. So that number is kind of in keeping with what we saw back in the 1990s with the Washington State Benjamin et al. Study. It also turns out about 36% had an audit C score that was consistent with hazardous drinking, alcohol abuse, or alcohol dependence. So let me tell you about what the audit C is. The audit C stands for the Alcohol Use Disorder Identification Test. The audit is under most circumstances a 10-item survey, a 10-item questionnaire. The audit C is actually a condensed version of the audit, and it asks questions only about consumption. So it's the consumption questions from the audit. And those questions are: how often did you have an alcoholic drink or a drink containing alcohol in the past year? How many alcohol containing drinks did you have on a typical day in the past year? And how often did you have 6 or more drinks on one occasion in the past year? Okay, so after being asked those 3 questions specifically, you can come up with a score for whether or not someone has hazardous or sort of non-hazardous alcohol consumption. What they found was that about a third of the sample had, over a third of the sample had an audit score that was consistent with hazardous drinking. And in fact, of that number, women were more likely than men to have that elevated score. 23%, that's almost 1 in 4, which I thought was kind of interesting and important to note, reported that alcohol or drugs were at some point in their life problematic. So there is sort of the development, or at least the presence of some awareness around problems related to alcohol or drug use. Same study, 23% reported that alcohol drugs were problematic at some point in life. Now, where they reported it is interesting. So 28% before law school. During law school, that number shrinks, probably because of the intensity of the workload. People are feeling very, very focused during that particular period of time. But get this, 44% within 15 years of completing law school. So as an organization, or in your practice or in your advocacy work, thinking through like, all right, well, who among attorneys are the most vulnerable? It's newer attorneys. And so maybe concentrating some efforts there might be helpful in reducing problematic alcohol or drug use. And then once people are more than 15 years out after completing law school, that number drops again significantly back down to sort of law school numbers. It turns out that higher alcohol consumption is much more probable among younger attorneys, which makes sense, 44%. And then of participants that endorse past 12-month use, the vast majority of folks actually endorse stimulant use, maybe speaking to that ADHD component that I mentioned before. So are people, quote unquote, self-medicating ADHD symptoms? Or is it really rather that because of the intensity of the workload, people and the demands of the workload, people need the additional energy and concentration and focus that are afforded by stimulus in order to sort of like have these, to sort of meet the unrealistic expectations of the job. 51% sedatives. So sedatives, thinking about things like benzodiazepines, barbiturates, which have sort of gone mostly out of favor in terms of treatment of anxiety, but are folks using self-medicating, treating their anxiety, or seeking out these kinds of medications in order to manage psychological distress? In addition, we've got 47% using tobacco and almost a third with cannabis use. When it comes to mental health, depression, more common among men. Anxiety and stress, more common among women. Non-problematic drinkers had lower levels of depression, anxiety, and stress. And those with senior positions within firms had an increased association with more depression, probably not terribly surprising. When it comes to the utilization of treatment, how many folks were actually going to treatment, there were only 7% of the folks that responded to this particular survey who actually reported that they had received alcohol or drug treatment in the past. But of that 7%, 22% used a treatment program that was tailored specifically to legal professionals. And it turns out that if you went to a program that was tailored to a legal professional, those folks had lower alcohol screening in comparison to those who did not attend some sort of specialty care focused on attorneys. When it comes to why it is that someone may or may not seek care among attorneys, not wanting others to find out they need help was number one. Number two, concerns regarding privacy or confidentiality. So when we think about stigma reduction, when we think about the impact of a diagnosis or the knowledge that someone went to treatment, how that can ultimately impact one's career trajectory, there certainly seems to be the impression among attorneys that that has an overall negative impact on the trajectory of their career. So a little bit about risk factors. So why are attorneys maybe a bit more likely to go on to develop mental health conditions or substance use disorders? Well, it turns out that temperament or personality, as we mentioned, has placed some role in this. It turns out that there are higher scores of neuroticism. Probably not entirely surprising. We sort of see high scores of neuroticism among physicians as well. But high scores of neuroticism might also sort of create a sensitivity to development of anxiety, as well as a sensitivity to trauma and potential to PTSD. There's also really, really high expectations of the self in the field. And like sort of a self-imposed perfectionism, like I've got to get this right. But if you get it wrong, you know, lives may be potentially in the balance, depending on the type of law you may practice. It also turns out that pessimists in law outperform optimists. And there's an interesting study that really looked at that as it relates to like, well, what are some of the qualities that pessimists have that might help them to be successful in the law? And really, it turns out that their ability to identify worst case scenarios actually works in their favor in their law. And in fact, the law is the only profession where pessimists outperform optimists. Shocking. By nature, your field is adversarial and competitive. Now, I'm in academic medicine, which can certainly become a little bit adversarial and competitive. But generally speaking, I think the practice of medicine and the practice of psychiatry, you know, there is like sort of this sense of like, I am part of a larger team, we're working together, that sort of thing. And so, you know, the adversarial piece of it, I think is really kind of interesting as we think about, well, how that might set someone up for experiencing greater anxiety and distress in conflict within their profession. I want to talk a little bit now about trauma. This was sort of an interesting idea because we think a lot about PTSD. We think about how under most circumstances, the individual has to have been directly exposed to trauma in order to be diagnosed with PTSD. But it turns out that exposure to vicarious trauma through work actually can qualify someone for a diagnosis of PTSD. So vicarious trauma really refers to the psychological effect that results from engaging in traumatic material. And so you can imagine that certain types of attorneys, particularly attorneys that might be in criminal law, where they're exposed to violent images and of people in various stages of undeath or death or injury, that the repeat exposure to that material might actually create for someone distress, and that distress might even begin to look like PTSD. PTSD, just sort of for the sake of the discussion, when we think about PTSD, we're talking about someone who not only has sort of nightmares, flashbacks, or sort of recurrent thoughts about traumatic material. That's one aspect of it. There's another aspect of it where people become more hypervigilant. They may startle a little bit more easily. Their sleep may be disrupted, and they may begin to avoid certain triggers or reminders of the traumatic material. So if there's a situation that might remind someone, people can become very avoidant. They may avoid certain media. They may avoid certain movies or television. That can be a part of it as well. And it can also be associated with, has to be associated with like the development of what we call negative alteration or negative cognition as it relates to mood. So beginning to see the world in a different way, maybe beginning to see the world more negatively as a result of trauma. So that collection of symptoms together constitutes PTSD, although the symptoms might also kind of resemble PTSD. So be thinking about that. If someone is in a position where they are exposed to a lot of trauma, then they may be more likely to go on to develop anxiety or PTSD. Turns out that there was another study, and this was a study that took place in Canada, that lawyers with moderate to high work-related trauma exposure, they also were more likely to have PTSD symptoms. They were also more likely to report psychological distress, as well as a poorer quality of life. So when you think about attorneys more broadly, and you're sort of identifying subcategories within the practice of law, who might be more potentially at risk, it turns out that folks that have a higher trauma exposure may be one of those subcategories to begin thinking about and focusing on. And in this particular study, they found that over 2.5 times more, there were lawyer with moderate to high work-related trauma exposure. Women, another subcategory. So in one survey of almost 3,000 lawyers in California and DC, 25% of women contemplated leaving the profession due to mental health, compared to only 17% of men. So that's a pretty significant stark disparity. And the number one reason that they cited, that women cited as part of the reason, was work-family conflict. So trying to straddle the fence, trying to be kind of everything at work and everything in the home, certainly can create for people a pretty significant amount of stress, strain, distress, and then that, of course, can contribute to desire to leave the profession. Overcommitment. It turns out that men are more likely to want to leave the profession because they feel overcommitted. And then finally, a permissiveness about alcohol in the workplace. So there are events that take place, meetings that take place, like my client that I mentioned before. I mean, part of his work is actually engaging with clients at dinners and at conferences where alcohol is served and the use of alcohol is promoted. So rates of depression and anxiety, stress, and problematic alcoholism are also higher among attorneys. Numerous risk factors contribute to this disparity. And among attorneys, women are particularly vulnerable to development of mental health conditions, which represent a risk for attrition. So in our final moments, let's talk a little bit about recovery, what that means, and then what it could look like specifically for attorneys. So defining recovery as a process of change through which individuals improve their health and wellness, live a self-directed life, strive to achieve their full potential. The 4 major dimensions of recovery are health, home, purpose, and community. And I took this definition directly from mentalhealth.gov. So there was a massive systematic review and meta-analysis that looked at well over 90 articles, studies that focused on what are the characteristics of the recovery journey. And I love this because I really feel like it kind of captures fully what so many people in recovery describe. It's an active process that is individual and unique, so that one's recovery doesn't necessarily have to look like the recovery of the person standing next to them. absolutely a nonlinear process. And people kind of conceptualize recovery as a journey. That's why we talk about the road to recovery. We talk about people on this journey, and that it occurs in stages and in phases. There's early recovery, there's sort of, I guess, middle recovery. And then once someone has been in recovery for a number of years, it's sort of like an established kind of recovery that people that are later in recovery or have long-term recovery that they can experience. There also is the recognition that recovery for some folks is a struggle. And that could look like developing stability as it relates to mental health symptoms, the reduction of alcohol or drug use, or complete cessation. That it is multidimensional, as we just mentioned, that it does talk about not just health, but also home, relationships, families, place in the community, that it's gradual, life-changing. And I love the part where they talk about we're not necessarily trying to move toward cure, and that really doesn't necessarily have to be a cure. I mean, people that are in recovery, both from substance use disorders as well as mental health condition, will tell you that they sometimes continue to struggle with symptoms of their disorder, but that they, despite those, or even I guess sometimes because of them, they make certain decisions in their lives to engage in community, engage with other people, and to participate in life in a different kind of way, despite the presence of those symptoms. It is, of course, aided by a supportive and healing environment, however the individual defines that. And it can occur without professional intervention. So the reality is that, I have to sort of remind that one of the things that I do here at Menninger is I oversee our addiction psychiatry fellowship. So I have learners and trainees that work with me. And I often tell them, the vast majority of people who make a change in their life related to alcohol, drugs, they do so without ever coming to see us. We don't really know about them. We don't hear about them. But this idea or this notion of spontaneous recovery is certainly real for people. And that doesn't necessarily mean that the person establishes abstinence, right? Like but they can experience sort of a change in their relationship to substances or alcohol that doesn't have anything to do with the Dr. Shorters of the world. And that there is a trial and error process that takes place for most people. So they try something and they're like, all right, well, that worked for me. I'm going to do more of that, versus that didn't work for me at all. I'm not going to keep with it. In terms of the processes that were identified in this study, connectedness. So of course, talking about being part of a community, we've talked a lot about that, but also finding peer support and peer relationships to really be critical in the development of a recovery process. Hope and optimism. Okay, now that might be particularly challenging among attorneys, where pessimism is actually rewarded and you are more likely to do well professionally if you are in fact pessimistic. So thinking about, okay, well, how can I use pessimism to my benefit in my career, but begin to develop a sense of hope and optimism in my life so that I can live and thrive in a different kind of way. That to me is probably one of the core components of what recovery must look like for someone who is in the practice of law. So part of it begins with believing in the possibility that recovery is even on the menu for the person. Developing a kind of motivation to change. I think a lot of the work that I do with folks is helping them to develop motivation. I can't expect that most people coming to see me are entirely motivated and inspired to make changes. But I believe that motivation is a process that is co-created by myself and the person or the family that I'm working with, because that just is my approach to it. And it's much more of a motivational enhancement therapy, motivational interviewing model. And we can talk about that later in the Q&A if there are additional questions. And also developing relationships with other people who can also help to inspire hope. So sometimes you borrow hope from other people. If you're not able to really develop it or get it for yourself, like taking a little bit of hope from somebody else and carrying that, allowing other people to hope on your behalf can be really, really helpful. When it comes to identity, it's really, people experience so much negative fallout, emotional fallout, psychological fallout as a result of having a mental health condition or having a substance use disorder. So part of the work that we do is we help people to sort of rebuild a positive sense of self. And a big part of that work is overcoming the stigma that's associated with having these conditions. So it's about developing honesty and speaking honestly with other people, maybe folks who have mental health condition or substance use disorder, and then talking about it with folks that don't have one, and sort of overcoming the stigma in that way. Developing meaning in life. And that's also making meaning of mental health experiences. What is it that I learned about myself because of my depression? What is it that I've learned about myself because of alcohol use disorder, because of drug use disorder? Focusing on quality of life, and also developing sort of meaningful roles and goals. So like, I'm not just an attorney. I'm not just a psychiatrist. I'm not just a physician. I'm all of these other things. I'm a son and a husband and a brother and all of these other things. And really investing those kinds of relationships with meaning in order to also develop a greater sense of connectedness and feeling like a part of a community. It turns out that in this particular study, that spirituality was not necessarily as high on the list as making meaning of mental health experiences, but it certainly is on the list. And spirituality can look very different from person to person. And that's why I think it goes back to that earlier point about an individual and unique process. And finally, a word about empowerment. People feeling like they can take personal responsibility and control over their life when things had maybe been so out of control for them. So personal responsibility for some people can be, I'd go to my therapy session every week, or I'd make sure I take my antidepressant every morning. I abstain from substances, or I really evaluate my relationship to substances. So all of that can also play into the empowerment piece. So when I think about pathways to recovery, and then I'll close, I think it's really important in the work that I do to really define a treatment goal. And so some people come in, and like the patient that I'm working with right now that I mentioned, his goal was not abstinence. He was not, now whether or not I believe he should be abstinent is beside the point. His goal for his treatment is not abstinent. So I think kind of talking through okay, well, what is an appropriate treatment goal for someone? And we'll try it your way. Meeting people where they are has got to be a critical component of the work that I do as an addiction psychiatrist. Of course, psychotherapy, either individual or group, is a major part of that. Medication therapy can be extraordinarily important. And really, I believe, again, for most people, can be a vital part of an overall recovery process. Not just with managing the withdrawal symptoms that people experience, but also reducing their craving or their desire to use substances, or to help them initiate abstinence. And of course, mutual help groups like AA, Smart Recovery, Refuge Recovery, these can be a critical component of the recovery process for folks. So when we think about how to promote recovery specifically among attorneys, based on some of the stuff that we've talked about and some of the data that we've seen, I think increasing support and monitoring of professionals within that 15-year period following graduation from law school is one thing that the profession can do to really kind of safeguard your younger attorneys. Enhancing support systems for professionals with colleagues and supervisors to address responses to client trauma as well as workload stress. We know that this vicarious trauma can certainly increase one's risk for PTSD or PTSD-like symptoms, and also the stress that people can experience as a result of their workload, overcommitment being a major factor for attrition among attorneys, as well as advocacy and creation of programs that are really tailored to treatment of legal professionals. As we saw, it turns out that there were lower alcohol screening scores among folks that had attended a treatment program that was tailored to lawyers. I think it's important to really think about self-care and positive thinking, and to try to figure out how to be a pessimist at work and an optimist in your life. But also beginning to kind of check and challenge some of the perfectionism that can come in with the job, allowing moments for vulnerability, or even lapses in discipline, especially around eating, because that type of disordered eating can be seen in higher rates among attorneys. And also looking at the culture in firms. Maybe there's a time for a culture change to take place there. What would flexible work look like, or flexible hours look like for women in the practice of law? What would it look like to reduce the amount of permissiveness related to alcohol consumption in firms and in practice settings? And then finally, the employment of mindfulness. And what would that look like from an attorney specific standpoint, right? So would people maybe be more likely to engage in mindfulness practices as a group or as a profession? And how could that be encouraged? So thank you. I'm going to stop now. We have a little bit of time left for questions and conversation. You're muted.
Thank you, Dr. Shorter. That was fantastic. There's a lot in that. I need to digest it, think about it. We have a few questions but before I go to the group questions, I have a question.
Yeah.
You had mentioned about recovery, and I said in the beginning that I'm in long-term recovery. Now that I'm here on the other side, if you will, I'm very grateful that I'm in this place. But before I got here, I had a lot of fear. Do you have any thoughts on how to help people realize how great it is to be more open-minded and willing and honest and things like that?
Yeah, so it's interesting because one of the things that I feel like we struggle with in medicine and as a field is that we oftentimes tell people all of the reasons why they should not engage in a behavior, and we do it from a very fear-based perspective. So to speak to the earlier part of the before of your journey, I feel like we unfortunately and inadvertently don't do enough to talk to people about their values. We don't do enough to talking about people's goals for themselves from a quality of life standpoint. And so I agree with you and think that part of my job, my work, is to help people shift from all of the reasons why they shouldn't engage in a behavior and really helping them to think through, well, what could your life look like if you are not engaging in that behavior? You know, we sort of have to talk a little bit more about both the pros and the cons of giving things up. I think, you know, when I work with patients, they most appreciate when I ask them two questions. What does using alcohol do for you? You know, like, can we at least acknowledge that there is a way in which this is not working for you? Sure, but there's a way that it is working for you too. So people feel more understood when you talk to them about, like, okay, I understand that some part of this is doing something for you. I may not like it, you may not like it all the time, but there is a plus in there for you. We have to at least acknowledge what that is. And we also have to talk a little bit about the loss that people experience when they give things up. So you want to give a more balanced picture, but part of that picture has to be about, like, all right, here's what you gain from no longer engaging in a particular behavior. So I think it's a great point.
Yeah, thank you. Billy had a question, but his question is about the models of addiction, but his question is not specific. You had mentioned there's lots of models. How do lawyers utilize some of those models to help themselves understand what they're going through?
Great question. Excellent question. I think that the reason that I use the models is to help people understand that it's complicated. Okay. So oftentimes people can get very stuck in really like a shame spiral, and or they get stuck in the belief that, like, I'm a bad person, or they get stuck in the belief that I'm engaging in this behavior because I am depressed or I'm anxious or I blank, whatever the blank is for the individual. And what I try to offer is that, sure, that may be true, but there are also other ways of understanding what's going on with you. And so trying to find a treatment provider or a group that fits your way of thinking, it has got to be kind of the first step. So sometimes people come into me and they say, listen, doc, I really resonate with AA, and I want to work a recovery program that's a 12-step oriented program. And I say, great, let's go with that. That works with your way of seeing yourself and seeing the world. If someone comes into me and they say, hey doc, I tried AA, I did 90 and 90. It wasn't easy for me, but it also, like, didn't land for me. my response to that person isn't necessarily just do another 90 and 90, right? It could also be, all right, well, maybe there are some other ways of understanding what's going on with you that do resonate with the person who you are. So perhaps at this point, maybe you try smart recovery, or you try refuge recovery, especially if someone has a mindfulness meditation orientation anyway, and they want to employ that as a part of their recovery process. I think refuge is a great place for those folks to go to begin pulling some of those meditations, because they're all available online, and there's groups and there's a book. So anyway, I say all of that to say, in the same way that we encourage people to individualize their treatment for everything else, for high blood pressure and diabetes, you have to find the right medication for someone, you have to find the right combination of medicines for somebody's cholesterol, for example, and they can't have side effects from it, and it should work on reducing their lipids. I think the same thing really is true for people with mental health and substance use disorders, where you individualize it, but you have to first kind of understand how you think about it, and then what treatment programs sort of match the way that you see it.
Right. And so Billy put in more specific his question.
Go.
His question is, can a person fall into more than one model
Yes.
of addiction? It seems like I fit into a few of the categories.
Absolutely. So I really think a unified model is probably the closer to the reality for people. And what I listen for is, what is the model that the individual is operating from in a particular moment, and how can we work with that model to promote recovery? So, example, if somebody comes into me and they say, they're a strict moral model thinking. They're like, I need to go back to church. I need to get right with God. And if I get right with God, I will be able to stay sober. I do not come in as a treatment provider and say, that's malarkey or hogwash, or I don't buy that. It's not necessarily my prevailing model of addiction, but it is for the person. So what I might say to that person is, all right, let's find a faith-based program for you. So if getting right with God or your higher power is what you would like to do as your treatment approach, then let's try to support you in finding recovery in that way. And at the same time that you're doing that, let's find a place that will allow you to take an antidepressant for your depression, or that will allow you to take naltrexone to reduce your alcohol consumption or desire to drink, so that it doesn't have to be one approach only. It can be a combination of approaches, some of my approach as well as some of theirs.
Great, thank you. We got 2 more minutes. I have one last question.
Okay.
You mentioned the word stigma.
Yeah.
For me, I had a lot of shame initially, and I've overcome that, and I'm grateful for that. But one of the things I'm trying to help with is to destigmatize mental health.
Sure.
It's more normal than we recognize. You have any thoughts on that?
Yeah. So I appreciate your personal efforts, because I do think that it does go a very long way with reducing stigma. We have to hear people's success stories. We have to hear that treatment works, that it's effective. I think we have done a really good job of defining the problem, and not as much of a good job talking about our successes. And so part of, I think, my job and my work is to tell people treatment works. Now, how we define works varies from person to person. So, like asking people to adhere to these very rigid ideas about what constitutes treatment success has been one of the major unfortunate flaws in, I think, our mental health system and the way we talked about our story. If I tell somebody, my goal for your depression treatment is for you to never be depressed ever again in your entire life, that's a setup, right? Because the reality is that, like, 1, we can't predict that, and 2, things happen in people's lives where they might become depressed. So rather than talking to somebody about saying, like, my goal for you is to never be anxious again, my goal, perhaps it's like, okay, well, the goal here is for us to support you even during periods of time where your anxiety is elevated, so that it doesn't negatively impact your quality of life, so that it doesn't negatively impact the nature of your relationships, so that it doesn't impact the way that you feel about yourself, that there's a recognition that this too shall pass. So there are different messages that I feel like we can give people that can help to overcome the stigma. But when we talk about it as an either or, you are either depressed or you're not depressed. You are either anxious or you're not anxious. You are either sober or you're not sober. Like, we set people up, and then it actually makes it a little bit more difficult for people to even consider entering some sort of recovery, some form of recovery, because they feel like the goals are so lofty and so high.
Great. Well, thank you. 1 o'clock. Thank you so much.
Thank you.
Very appreciative. That was a great presentation. Thank you all for coming. Thank you all for listening. And please share what you've learned with others, and please let other people know about the presentation, because it's great information. Thanks, Dr. Shorter. Thank you all. Have a great day.